Thank you very much, William. So now I'm going to finish off the safety section with a few further very important areas. The first is malignancy. And so far, the rates of malignancy are very low. There is maybe a slight increased risk of non-melanoma skin cancer. We see this with biologic agents, but they're really similar rates with all treatment groups and patient populations. The rates are low, and really there is no flag with malignancy so far in ankylosing spondylitis with upadacitinib. As I mentioned, non-melanoma skin cancer, not common, numerically slightly higher rates, but again, really consistent with what we've seen with advanced therapies. And this is something that we can easily manage in the clinic. And we're very used to doing that, of course, in Australia. Basal cell carcinoma, most common type of malignancy in RA and PSA. And there was actually only one event of malignancy in SCC in the AS population. What about major adverse cardiovascular events? This is, of course, critical. It's very topical at the moment. Really no flag that we see in this population. In fact, in the entire safety data with RA, PSA, and AS, we haven't seen an increased rate above that we would expect in this population. In fact, there were no cases of MACE in the Select Access 1 study. And if MACE does occur, it's in cardiovascular patients with risk factors. And of course, we're monitoring these very carefully. That should be part of our role as rheumatologists monitoring cardiovascular health. Another very topical area is venous thromboembolic events. And here we have the rates in the phase 3 data, RA, PSA, and the AS studies. Similar rates of adjudicated VT were observed in all treatments in RA and PSA, and the VT events occurred in patients with greater than or equal to one identifiable risk factor. If you look at the actual numbers here, this is exactly what we would expect in the background rate of patients with active disease. So it's around the 5 events per 1,000 patient years, and there's no flag with UPA across these different patient groups. Here we look at the risk factors. Again, we need to embrace cardiovascular disease as a rheumatological condition. I was indoctrinated in Cambridge about this, and that we need to be monitoring or at least sharing the care with the primary care, the blood pressure, diabetes, cholesterol, smoking, and we really need to control all of these or monitor them to optimize the care of the individual. But here again, in the phase 3 trials, in this one, in rheumatoid arthritis, we do not see an increased rate of VTE. And in those who did have events, there were cardiovascular risk factors. So overall, I'd like to summarize by saying that we now have data in nearly 4,300 patients across RA, PSA, and ankylosing spondylitis who received UPA 15 milligrams, the licensed dose, and we have over 8,500 patient years of exposure. When we look at the ankylosing spondylitis population, the side effect profile is extremely favorable, and we have minimal in the way of adverse events. Again, this may reflect the younger age of these patients with less comorbidities. Nevertheless, it is a very favorable safety profile of UPA in this group, and really similar to what we've seen in PSA and RA. So herpes zoster, we know that's elevated, that's a class effect, more in Asian populations, and we can now potentially mitigate that with vaccinations, particularly Shingrix, but we do warn people about herpes zoster. And I believe it's not so common in the Gulf, and I'd be very keen to discuss this further in the discussion time, which is really where we can deep dive further into the data. And in the RA populations, higher rates of herpes zoster, as mentioned, and elevation in CK. We don't monitor this. It doesn't appear to be a problem in relation to clinical manifestations. If people do complain of myalgia or weakness, then of course we would check their CK, but that's not routine. Now we have safety data out to 4.5 years of patients in RA, and we've not seen any new flags or new concerns over that we've seen already in the safety profile in the clinical trial experience. So the safety profile of Uber 15 milligrams in patients with PSA and AS consistent with that observed in RA, with no new safety signals observed. Thank you again for your attention.